As you heard, I'm an internist. I'm trained as a general internist, and I was fortunate enough to train with Bob at UCSF, specifically at San Francisco General, from 1983 to 1986. Those of you who are old enough to remember what San Francisco General was like in 1983, our first night on call, we admitted 3 or 4 young men to the hospital with these incredibly bizarre infections. Toxoplasmosis, pneumocystis carinii pneumonia. And 3 years later, I knew more about what we eventually came to call HIV disease than most doctors in the world. I then went on to do an MBA at the Wharton School, helped start the HIV clinic at Penn, ran the AIDS clinic at Johns Hopkins, and then came back to California to work in philanthropy for 22 years. But throughout that time, all of my contracts with my employers gave me half a day a week, unpaid, to volunteer to work in the AIDS clinic at San Francisco General, where I still work. My dwindling number of patients and I are aging together. They more gracefully, I think, than I. But I wanted to start with that in part because there were so many echoes of that experience in what you were talking about a minute ago. One of them has to do with pharma and the promise of pharma. So last week I talked to a patient of mine who's 79 years old. He's on 1 pill once a day for his HIV. It's a miracle. It's a miracle. I take more medicine than he takes. This whole point about drugs being expensive and getting to be cheaper as the patent system wears off, and there's lots to talk about patents, but it's worth thinking about how much pharma has transformed that disease, how much the explosion of research and knowledge about virology prepared us for the last pandemic we just went through, including the invention of mRNA, which didn't work for HIV, but turns out does work for COVID. It's just worth thinking about maybe not the effectiveness of this first Alzheimer's drug, but the next one, or the one after that, or the combination of 2 or 3 that turned out to transform the life of my 79-year-old patient. No one ever expects a huge outpouring of sympathy for, concern about, and action on equity, and certainly no one ever expects a worldwide pandemic, except some people actually did expect that. And one of the great tragedies of the pandemic is, I think, one might have reasonably assumed ahead of time that a disease that horrible and that undistinguishing of lots of characteristics would unite the country, right? Would bring to an end the divisions and the acrimony of the country. And tragically, that was not the case. I have friends, as some of you perhaps have, who are public health leaders who wear flak jackets to work and have armed security from people who threaten them and their families. These are people who make not even what nurse practitioners make, trying to save our lives, who face that kind of attention. So let's talk about the pandemic, and let's talk about equity. And those two things are actually linked. I don't know how much you remember those early days of March and April and May of 2020, and the mainstream kind of lay media talking about the fact, noticing the fact that it seemed that black and brown people were kind of getting sicker, were getting more hospitalized, were dying more than non-black and brown people. And the explanation given for that was that they had more pre-existing conditions. And there were 2 problems with that. One was that it wasn't true. That is to say, that explained part of why we were getting sicker, more hospitalized, more dying than others. But it also had to do with who had to drive the bus or the train, who had multi-generational households, who was working shoulder to shoulder in a meat packing plant. Had nothing to do with pre-existing conditions. Had to do with the social conditions, the broad tapestry of distinctions and discrepancies in American life that made some people more vulnerable to the pandemic than others. But of course, the other problem was no one ever asked, well, how come they have more pre-existing conditions in the first place? which of course leads us to part of the interconnection between the pandemic and the consciousness about equity, because it was the summer of George Floyd and Ahmaud Arbery and Breonna Taylor. It seemed like at the time, every week, some new outrage that actually mobilized people of all races and classes and political parties in this country and around the world. There were marches in Berlin and Paris and Idaho. Why? Well, part of it was the fact that these things were televised, were visual, were in people's faces, and again, followed one after another. But there are another couple of reasons that I think are worth thinking about. One of them is the growth in the last 20 years of the consciousness of so-called social determinants of health. If you go to Medline and look at the number of articles that cite that phrase, there's a steep rise starting in 1990 and accelerating through the mid-teens. In the years 2015 to 2019, there were more articles quoting social determinants of health than in the entire previous 30 years. So our profession, our field, had been primed with the knowledge that a lot of the reasons that some people were healthy and others were unhealthy had less to do with access to medical care itself and to broader issues of where they lived, how they grew up, what services, transportation, food, and others were available in their community, etc. This is not a new notion. You can go back to Rudolf Virchow. You can go back to the Whitehall studies that after 25 years showed in England a very clear stratification of mortality based on your economic class and education. Clerical workers, administrative workers, executives, over 25 years. So not a new thing, but perhaps newly appreciated in the American healthcare system with new research. My own view is that equity, though it is perhaps most prominently associated with race in this last period, has to do with an aspect of medical quality. 20 years ago, the IOM developed and promulgated what I think is still the best definition of quality. It has 6 domains. You all know them by heart, right? Quality means that healthcare is, safe, effective, efficient, timely, patient-centered, and equitable. Equitable. That is to say, care should not vary between individuals based on their characteristics. What does that mean? Well, race is certainly one of them. Gender is certainly one of them. Whether or not you speak English as a first language, whether you are literate is one of them. Whether you have a sexual preference that puts you in some disadvantage with regard to care, perhaps religion or visible marks of your religion. Certainly location. People who live in some areas are living in care deserts and are disadvantaged with regard to care. So for me, I always try to put equity in the frame of quality. Why? Because I have a certain political and social view, and you may have a political social view, but I and my colleagues and your colleagues should not regard equity as something that is optional based on their social view or necessarily have to agree with mine. Do you understand what I'm saying? So I grew up in Brooklyn. Not everybody who's a healthcare provider in Brooklyn has the same view of, say, Malcolm X. You shouldn't have to agree with my view of Malcolm X in order to be concerned with and professionally responsible for eliminating unequitable treatment. So my advice is always, and my advice to you is, start with quality, because we should be providing the same quality care to everyone, and we should all have a professional responsibility and commitment to providing high quality care to everyone without regard to deeper social and political views. And for that, you start with whatever your most important quality measures are. There's an orthopedic surgeon here, there's a radiologist. You've got some quality measures. Revision rates, infection rates. If you're an administrator, readmission rates. If you're a CFO, debt collection aggressiveness or pain control. Start with whatever your important quality measure is. I'm not telling you what's important. You're telling me what's important, and then analyze it by race, by gender, by principal language, by zip code. Analyze it by the criteria, the dimensions that we know have inequities, and you will find work to do. Do you understand what I'm saying? Part of the reason I say this is because equity has become so important now, there's a certain kind of performative aspect to it. By 2022, 75% of Standard & Poor's 500 companies had a chief diversity officer. Not sure what all of them were doing. I'm not. But I know when I go to a hospital that tells me they are paying attention to social determinants and they have a farmer's market in the lobby on Saturdays, and I ask them, have they analyzed their discharge rates by race? And they say, oh, sounds a little performative to me. So the point I'm trying to make is that equity is, in my view, an aspect of quality. It should be treated as an aspect of quality to which all of our professional colleagues should be held without regard to political views. And also, importantly, the tools to work on inequities are quality improvement tools. They are PDSA cycles. They are the standard toolbox of IHI and other quality improvement organizations. And so when you find that there is inequity in terms of reinfection rates or aggressiveness in pursuing collections or pain control or discharge from the ER without medical treatment or restraints, the same tools used for other quality issues, issues of effectiveness, efficiency, timeliness, patient-centeredness, have to be used with equity as well. It's also, I think, important to apply an equity lens to policies and procedures. Does that mean it trumps the other aspects? It doesn't. But there are lots of circumstances in which one domain of quality may be in some conflict or tension with another. One can imagine circumstances in which, in your drive to be efficient, you become unsafe. In your drive to become patient-centered, you wind up doing things that are not effective. If, for instance, you have a Medicare hospital payment policy in a COVID emergency that is efficient because you're using old formulae to develop payments to hospitals, and it turns out those weren't the hospitals that had the COVID, you didn't apply an equity lens to the policy or procedure that you're doing. And so I suggest in everything we do, all 6 domains of quality need to be understood, and you need to have an equity lens to make sure that you're not harming one aspect in service of another. So now let's talk a little bit about the COVID pandemic. The pandemic introduced millions of Americans and hundreds of thousands of doctors and advanced practice nurses and other healthcare providers to the notion of virtual care. So let me talk for a minute about the word virtual. Virtual used to mean almost but not quite, right? If you said you were virtually certain, that meant you were almost certain but not quite, right? You say this horse is a virtual lock. Not quite a lock. So it's interesting to even think about the way virtual has been transformed from almost but not quite to now kind of meaning you're using electrons. But the fact of the matter is, 20 years ago, we started doing virtual banking. And 15 years ago, we started doing virtual travel agenting. But now we don't think of it like that. We think of it as banking and travel agenting. Now, there are still tellers, and there are still travel agents, few anyway. And most of us would use perhaps a travel agent if we were doing a complicated worldwide trip. But to fly southwest from Ontario to Oakland, do you really need a travel agent? Or to withdraw $20 from the bank or deposit your paycheck, do you need a teller? The problem we have is the equivalent of letting tellers decide about the diffusion of ATM machines. We've let doctors decide about the diffusion of models of care that don't fit with the business model that most doctors have. So it shouldn't be surprising that healthcare has been essentially 20 years behind the times in terms of transforming the way in which people interact and get paid. Was that moment, as a friend of mine said, plastic or elastic? Was that moment going to lead to permanent change in the way we do things, or will it snap back to the way it was ex post ante? I suspect it's some of both, but I'm absolutely convinced that for patients and for doctors, they will never again, without at least thinking about it, try to think about, do I really need to go drive across town, find a parking place, park, wait in the waiting room, be checked in, do all that for like a 10-minute interaction to exchange some information? Do I really need to do that? I certainly don't travel the way I used to. Just, you have to meet 4 times a year, so we get on the plane and we drive and fly to New York and spend 3 hours of FaceTime. So I think we should look for a world in which all practices, whatever your specialty is, pathology, I don't know, but almost all practices, will need 4 channels. There'll always be a need for in-person bricks and mortar. There is video. There is asynchronous interaction, text messages and email and things, and where both people don't have to be online communicating with each other simultaneously. And then there's phone. And don't forget phone. There are a lot of people who either don't have broadband or who may not want their doctor looking over their shoulder at their house because they got 5 kids and only one place where the computer is. But whether it's wound management or blood pressure assessment or almost anything, surgical post-op, the technology to avoid bricks and mortar personal interaction now exists. And the platform broadly exists. And the question is, can we set up a payment environment and operational efficiencies to take advantage of that technology, as they have in almost every other service industry? Remember, we're the only service industry that has institutionalized a waiting room, right? That has said essentially to our patients, our customers, my time is more important than yours, right? So think about the possibilities. Having spent time in places that have really committed to lean management, having seen people transform an operation that was kind of bloated and inefficient and irrational in a relatively short period of time with a method, sometimes the results can be nothing short of astonishing. So to the extent that some of the pressure waiting on this system, day after day, time after time, reduce costs, to the extent that it transforms our willingness to take a look at the way we do business, at the internal operations of everything from our institutions to our clinical care delivery, I'm actually quite optimistic about the capacity to wring inefficiencies out of our system. I recognize that culturally the question is how much of that money goes back to the payers rather than being absorbed by others in the system. But I actually am optimistic that some of this pressure, if handled right, can lead to care that is both better and cheaper and substantially more convenient for patients. I think we've got to figure out how we transform people's expectations about their incomes, about their autonomy. My first week in medical school, I was congratulated by some faculty member for having chosen the last profession in America where nobody could tell me what to do, right? So a lot of the people who are doctors in part because they're running away from organizational responsibility, from management, from organization itself. You're going to have to get over that. And the next generation, I think, is largely getting over it, but we're going to have to transform our organizations. I know that's what a lot of you are doing, but I'm actually optimistic that some of the pressure of the pandemic opened our eyes to doing things in a new way, and I hope that a lot of that becomes plastic rather than elastic. This issue of equity is difficult for lots of people because it raises other complicated questions of our own political and racial identities and the history of the country and a lot of stuff. I've seen it tear organizations apart internally. I've seen it let people get stuck in ways that they shouldn't get stuck. But it is vitally important because it does go to the mission of what we're here to do. We're here to provide care for people, and as I said, in my view, equity is an irrevocable part of quality. It ought to be treated as such. It ought to be a primary professional responsibility of us as individuals and us as organizational beings. And if we start with the quality measures that are most important to our institutions, to our specialties, to our practice partners, and look at them in clear-eyed fashion about whether everybody gets the same outcomes, whether everybody is getting the same quality care, there will be more than enough work for us to go to work on keeping quality as the North Star of the philosophical kind of environment in which we work.